Hello, and welcome to your lecture on the pathophysiology of pain. I'm your faculty, Professor Brooks. First, we will discuss an overview of noxious stimuli. Noxious, or another word for unpleasant, often refers to pain in the medical community. You may hear, does your patient respond to noxious stimuli when referring to the P on the AVPU scale. Nociception, or the perception of pain, is built into the nervous system through nociceptors. Nociceptors are the receptors of the nervous system that detect noxious stimuli and then translate the stimulus to the perception of pain. They are unevenly distributed, and this is important to understand as nurses. When we perform tasks, they can be pain-provoking. So if we can, we want to eliminate those that we can, those that cause pain, or reduce the frequency and clustering of those tasks, or prophylactically treat pain before those tasks. For example, placing an IV can be painful for most patients. However, location of nociceptors should be considered. Placing an IV in the forearm or the antecubital is usually less painful than in the hand due to the distribution of nociceptors. Let's look at table 15.1 on page 327 in Huther and McCants. Notice the highlights of inflammation. If we look at the skin, we notice stimuli of pricking, cutting, crushing, burning, freezing, and inflammation. We have talked about how inflammation causes pain. This table illustrates the amount of inflammatory pain experienced in different parts of the body. So now we need to talk about the physiologic response to nociception. If your patient is having acute pain, they will have SNS stimulation. This is triggering the flight or fight response. So our body releases epinephrine, norepinephrine, and activates RAS. We get tachycardia from beta 1, elevated blood pressure from alpha 1, beta 1, and beta 2, increased respiratory rate from beta 2, hyperglycemia from alpha 1 and beta 2, and decreased urine output from alpha 1. However, in chronic pain, many patients do not experience SNS responses. In fact, even with acute pain in a patient with chronic pain, SNS responses are not always triggered. This is important in our assessment, especially in chronic pain. I've heard many nurses say, "Oh look, no tachycardia, so that patient can't be in that much pain." So vital signs can help us identify pain, but much like cyanosis, they are not diagnostic of pain responses themselves. Now let's move on to the neuroanatomy of pain. What are the physical structures that function in the pain stimulus pathways? How does the system receive messages and respond to those messages? So the classic example used is when someone touches a hot stove. This thermal change stimulates the nociceptors in the fingertips and the hand. This then stimulates electrolyte release in the nociceptors, causing a nerve impulse to travel up the afferent pathway, then to the brain for interpretation, and then down the efferent pathway back to the hand. This is the neuromuscular response that then says, pull your hand away, that hurts. This is a very rapid response and provides a safety mechanism to prevent further injury. This situation is considered acute pain. Let's look at the image of the dorsal horn on the slide. When examining acute pain, we have alpha delta fibers. Those are indicated in red. The red path demonstrates the painful stimulus traveling up the dorsal horn through the myelinated nerve conduction system. This allows the impulses to travel rapidly and reaches the thalamus and the somatosensory cortex for interpretation as acute pain. However, before we interpret the pain, the alpha-delta path triggers a spinal reflex that pulls the hand away from the hot stove. This is referred to as the anterior spinothalamic tract. Our other nociceptors are there to indicate dull, aching, burning, or chronic pain. And these nociceptors follow the C fibers. So alpha-delta fibers for acute pain and C fibers for chronic pain. These fibers are most numerous and unmyelinated, which means they transmit the nerve impulses slowly. These are most commonly found in muscles, tendons, organs, and in the skin, and transmit continuous or intermittent stimuli. In our diagram, this is the green pathway. As we follow the C fiber, we can see it branches into two paths and is recognized in various parts of the dorsal horn. On the impulse path, it first leads to the brainstem reticular formation, then travels to the thalamus and the somatosensory cortex for interpretation, just as in acute pain. Since the C fiber moves through extra interpretive areas, this can lead to some problems with chronic pain perception and sensation. Notice that there is not a direct neuromuscular or spinal reflex response in the C fiber pathway. So often, chronic pain is not as purposeful as acute pain is. Pain transmission is facilitated by these alpha, delta, and C fibers, which synapse with excitatory or inhibitory interneurons in the dorsal horn. Pain facilitators are familiar, as we've discussed histamine, prostaglandin, and bradykinin in detail in 331. These three substances are facilitators of pain stimuli and found in situations of inflammation. Inhibitors of pain include endogenous opioids, GABA, which is gamma-aminobutyric acid, endogenous cannabinoids, and some other feel-good neurotransmitters like serotonin. So neuromodulation of pain involves the excitatory and inhibitory chemicals that I mentioned on the previous slide. Excitatory neurotransmitters are purposeful and involved in injury and inflammation. They increase sensitivity and responsiveness to pain. For example, a person can sprain their ankle and it hurts. As they walk on this painful inflammatory injury, their ankle gets more sensitive to stimulation and causes the person to stop walking on the affected ankle. This gives the body time to heal. So in this case, the excitatory function is purposeful in allowing the injury to heal. Inhibitory neurotransmitters are things like GABA. GABA is released in excess during alcohol intoxication. So think of that state of drunkenness when you feel like, think of the state of drunkenness when you think of the function of GABA. It mimics that intoxicated feeling. Endogenous opioids produced by the body not to be confused with our exogenous opioids taken as medications or drugs. These chemicals are a natural morphine-like neuropeptide. They tend to trigger pleasure responses similar to the runner's high, or found in the case of an orgasm. They can help you overcome some painful stimuli, and they actually produce positive feelings from something that might normally be painful. These are associated with the endorphins. Opioid receptors are known as different categories: mu, kappa, or delta varieties. Mu receptors are the most plentiful and have high concentrations in the GI tract, especially in the intestines. This can explain how exogenous opioids affect the GI tract function. Exogenous opioids attach to the mu receptor and inhibit nerve impulses, leading to a slowed peristalsis and potential constipation with chronic use of opioids. Our image on this slide demonstrates how the inhibitory pathway works. The afferent pathway sends a painful stimulus up through the dorsal horn. The efferent pathway sends an inhibitory impulse from the brain toward that afferent path. Here, the endogenous opioid binds to the opioid receptor, stimulates endorphin release, and blocks the opening of ion-gated channels, thus preventing further pain impulse transmission. Our next topic is pain perception. It is certainly what the person says it is, as we've learned. As nurses, we need to be cautious about our own bias and perception, and focus on what our patient says their interpretation of pain is. There are three main areas of pain perception. We have sensory discriminative, which allows the patient to describe their pain. We commonly use PQRST mnemonic to assess the patient's pain. So what provokes the pain? What makes it worse or triggers it? What is the quality of the pain? This is often a difficult question for patients. So we can lead them by giving them options such as, is your pain dull, aching, sharp, or crushing? Where is the region of pain located, and does it radiate? Being able to correctly describe where the pain is can help us differentiate causes. For example, gallbladder pain can refer to the right shoulder. Another example is jaw pain and how it can connect to MI and cardiac pain. How severe is the pain? Use of a pain scale is recommended, and we often use a 0 to 10 scale. However, this may not be understood as well. So we can use other scales, such as FLAC or FACES. How long has the pain been present? Our next area of pain perception is the affective motivational system. This system deals with how the patient feels about the pain. The person may have a conditioned avoidance to pain. Patients who have had similar or the same pain in the past can often have an emotional response to the pain. For example, a patient who says that they have been in the hospital in the past may have had an emotional response to the potential pain of IV placement, especially if this has not gone well. Even before the procedure begins, the anticipation of the pain can lead to responses physiologically. Lastly, we have our cognitive evaluative system. This is very similar to the affective motivational system, but it has a few key differences. In the cognitive evaluative system, there is more of a learned response to pain, rather than an emotional response. The patient expects a certain pattern of stimuli from their pain. For example, if a person has had an IV in the past, they expect the pinch and burn sensation, or maybe they expect a horrible amount of pain, depending on their perceptions. This can also be the case of a learned response of a patient to modulate pain. Individual patients may choose to use visualization, music, meditation, or some other form of behavior to modulate their pain. And this might have worked for them in the past and been a good strategy to modulate their pain. Next, let's talk about pain perception. The first part of pain perception is pain threshold. This is another important aspect of pain perception. Pain perception is the minimum amount of stimulus needed for a person to recognize pain is happening. A good example is the mosquito. A mosquito lands on your arm and bites you, injecting lidocaine, an anesthetic, into the area of the bite. Most people do not recognize that the mosquito has landed or even bitten you initially, because there's not enough of a stimulus from the small insect or the initial bite that injects the lidocaine. You only begin to recognize the presence of the mosquito when the bite goes deep enough to stimulate a nociceptor, or when the inflammation builds up to a point of detection. This is similar amongst most individuals. So most people do not feel the initial bite or the mosquito landing, but it takes a little bit of time for them to detect that pain from a mosquito bite. Another concept, known as perceptual dominance, is when pain at one location alters the pain threshold at another location. An example is a patient who comes into the emergency room after a motor vehicle accident and is complaining of severe chest pain from hitting the steering wheel. They may have an aortic tear and chest contusions, pulmonary edema, and pleural effusions. This individual focuses on the severe, sharp, tearing pain found in the chest, but they do not perceive the pain in their leg that is there from a tibia-fibula fracture. Often, the more severe or life-threatening injury is perceived, while the other less threatening pains or injuries are not perceived due to this phenomenon known as perceptual dominance. Pain tolerance is a third concept. Pain tolerance is where we as nurses must establish mutual trust. When you're working with a patient in pain, they need to be able to feel safe. Pain stimulates an inherent feeling of danger and stress, as we know through the flight or fight system. Patients in pain need this trusting situation so that they can feel safe communicating their perception of pain to you. You need a realistic description of pain from the patient to accurately assess and treat their pain. Often, we try to establish this trust from the beginning, but it does take time to build. So we can approach it by saying things like, "I will do whatever I can to help you with your pain. So I need to know the details in order to accurately treat your pain." Sometimes, non-pharmacologic interventions work well, while in other cases, we need pharmacologic interventions. This establishment of mutual trust can work in many situations. Often patients will over-report their pain scale to obtain treatment because they do not feel that they will get appropriate treatment without a high pain score. This might be due to many factors, like past experiences, tolerance, cultural factors, and many more. In other cases, patients are reluctant to report pain, possibly due to beliefs on pain management or pain management systems themselves, which can impair or delay healing. I'm sure that you've heard the situation of, well, that patient says they have 10 out of 10 pain, but they're laughing and they're on their phone. Or maybe you've heard of the patient who says, I don't want to bother you for pain medication because you're so busy and I can deal with the pain. These are both examples of situations where trusting relationships can be established and better assessment of pain can be obtained, leading to potential better outcomes. Pain tolerance differs from pain threshold in the fact that tolerance is the greatest amount of pain that a patient can endure. This has a lot of variation amongst individuals and can even vary within one individual, depending on many different factors. So let's explore the concept of pain tolerance a little bit further. When a patient comes to the hospital, there can be many reasons for lowered pain tolerance. The mere presence of being in the hospital can lower tolerance, possibly related to the illness and the presence of pain relief options. Anger, anxiety, depression, fear, all can lower the tolerance of pain. Often this is exacerbated in patients who are poorly informed of their course of hospital stay. Anger or being upset because they do not know what is happening can be a frequent contributing factor to a lowered pain tolerance. Depression links to pain as well, and often increased perception of pain and decreased pain tolerance are linked to the pathophysiology of depressive disorders. Isolation from normal coping mechanisms that increase pain tolerance, such as familiar people, comfortable furniture, familiar surroundings, adequate temperature control, and pets, can also contribute to lowered pain tolerance. Chronic pain often alters pain tolerance as well. Quite commonly in caring for a person with chronic pain, I've performed an intervention that typically is not pain-inducing, such as helping a patient turn. And the patient with chronic pain has an emotional or learned response to the intervention based on a decreased pain tolerance. It is then your job as the nurse to remember this, apologize for the pain, and build that trust back up again, providing safety and comfort. Tiredness and fatigue also decrease pain tolerance. As nurses, we want to increase the patient's pain tolerance when possible, and we often can do so with nursing interventions. We can provide diversion and allow the patient to refocus their mind away from the pain and toward relaxation and comfort. Television, music, reading, familiar visitors, therapy animals, and many other diversion techniques can be useful in increasing pain tolerance. Allowing for adequate rest can be a pain tolerance raising intervention as well. So we choose to cluster our care to allow the patient to have breaks from interruptions to their rest and sleep. We can call the phlebotomist and arrange a time for blood draws and care combined. We can pass meds and assess and provide hygiene all in one time period. There are many different techniques and ways to achieve this. Alcohol is another pain tolerance increaser. Now, we aren't going to use alcohol as a nursing intervention in most cases, but it does increase pain tolerance. We often have patients who utilize alcohol or other substances like nicotine to cope with stress, pain included. There are negative effects in these mechanisms, as we are well aware. Medications are often one of the most common tolerance increasers. We tend to jump to the pharmacologic interventions immediately, but as we know, Adverse effects come with medication use as well. Finally, we have culture. There are some cultural factors that permit a person to feel more pain without it being physically or emotionally demonstrated. We often refer to stoic cultures when pain is involved. While these patients experience pain, they may not complain of pain or seek interventions to remedy that pain due to these cultural factors. These patients need even more mutual trust establishment. For example, a stoic patient may not ambulate as frequently due to the pain, but will also not ask for pain medication. This patient needs to have the risks and benefits explained, and a mutually beneficial compromise may be able to be reached, which will then improve outcomes for the patient's well-being. Okay, let's move on to the classification of pain. We have acute pain, which is sudden and often responds to treatment interventions. As an example, a patient comes in with 10 out of 10 abdominal pain, and after administration of an opioid pain medication, that pain scale rating decreases. It is associated with injury or acute pathophysiologic changes like inflammation. We can have acute on chronic pain, where an individual with chronic pain has an exacerbation of pain. For example, a person with chronic back pain is involved in a fall and now has exacerbation of the back pain due to a new injury. This is an increase in pain from the new injury, but with a background level of chronic pain. This pain is very difficult to treat due to the tolerance of pain and the use of chronic medications and tolerance to those medications. In the case of acute on chronic pain, we often need to administer 20 to 40% more opioid pain medication to treat that acute portion of pain beyond what the individual would normally take to treat their chronic pain. Chronic pain is persistent pain. It has times of exacerbation and reoccurrences. To classify chronic pain, it must occur for greater than 3 months. Chronic pain is resistant to pharmacologic treatment due to medications not working in the C fibers like they do in the alpha-delta fibers. These pain medications do work, but you need higher doses of them to be effective. The patient who takes regular pain medications can build a physiologic tolerance to the effects of the medication, and subsequently may need more medication to obtain pain relief. This can lead to addiction and dependency, and an ineffective pain management program. Opioids, which are very effective for acute pain, are not as effective for chronic pain management. We can further classify pain in the frame of acute and chronic pain. Somatic pain is an acute type of pain from the skin, bones, joints, or muscles. This is typified by a sprained ankle. It is often sharp, dull, achy, throbbing, and may be localized well or poorly. Somatic acute pain is best treated with non-steroidal anti-inflammatory drugs, or NSAIDs, to manage the inflammation, reduce edema, and relieve pressure on the nerves. In addition, it can decrease histamine, prostaglandin, and bradykinin's actions. Visceral pain is abdominal pain, internal organ pain, and body cavity lining pain. It may be acute or chronic, depending on the underlying cause. For example, gallbladder pain from cholecystitis or an inflamed gallbladder, leads to poorly localized pain that is aching, throbbing, or cramping, and often radiates and refers to another area of the body. In this case, it is often referred to the right shoulder. Visceral pain is an SNS issue and can involve nausea, vomiting, hypotension, and shock. Opioids are the treatment of choice to manage acute visceral pain. Referred pain can be acute or chronic and refers from an organ to another area. For example, cardiac ischemia can lead to acute chest pain, but also refers to the left neck, jaw, shoulder, and arm. In chronic cholecystitis, the referral to the right shoulder is present. Neuropathic pain relates to nerve damage that does not improve. Once nerves are damaged, regeneration is not possible in many cases, so permanent damage and dysfunction can occur. And this can lead to chronic, difficult to manage and treat pain. Neuropathic pain is increased in response to painful stimuli, known as hyperalgesia. An example is diabetic neuropathy. In many cases, even placing a sheet over an individual's toes with neuropathic pain causes an inappropriate neuronal response, and pain is perceived. It is often described as a burning or electric feeling pain that shoots upward through a limb. The last pain classification is known as phantom pain. Phantom pain is a chronic pain. This is the result of an amputation. The patient still feels the limb that was amputated and can even feel pain in that limb even though it has been amputated. This involves nerve and spinal stimuli being interpreted differently due to the amputation. This pain is notoriously difficult to treat. So lastly, let's look at the referred pain image. We talked about it previously, such as cardiac pain in the arm or gallbladder, pain to the right shoulder. Appendicitis occurs over the appendix, but refers to the umbilical area and right lower abdomen in general. Bladder pain can be located at the neck and the apex of the bladder, but also can refer to the posterior inner thigh. These are good things to be aware of when assessing your patient's pain.